what we're going to cover today: depression, anxiety, psychosis, and then we're going to tie it in with a case study. We know depression and anxiety is what we call high prevalence disorders because they're most prevalent in our community. And back in 2007, there was a national survey for mental health and wellbeing by the Australian government, world-class first survey of its kind on the planet, really. And what they discovered was there was a high proportion of people living in our community with untreated, undiagnosed anxiety and depression, and as a result of that we've seen things like Beyond Blue. There was a previous study back in 97, I think, as well. So as a result of these surveys, it was uncovered that people are living in our community undiagnosed and untreated with anxiety and depression. That's why there's been a really big push through lots of initiatives, one of them being Beyond Blue, to get people treated and to seek help. So we know in our community, in Australia, the ages between 16 and 85, 6.2% of the population will live with a mood disorder, so that's quite high. And we know depression often co-occurs with anxiety and other mental illnesses like schizophrenia. So let's have a brainstorming session. What words would we use other than depression? Some people may not identify as being depressed, bad, sad, stressed, low, angry, and what was the other one? Flat. Yeah, so people may not identify as feeling depressed, but what you may be observing is some of those things. Sad, they might have the blues, like they might feel down, low mood, miserable. So it's just to keep in mind some of the language when you're using, that you may not have to use the word depression, and they may not use the word depression either. What about signs and symptoms? If we're talking about depression, what are the signs and symptoms that we may see and observe?
Withdrawal.
Yeah, they start to withdraw from normal activity.
Poor self-care.
Poor self-care, yeah. What's the other?
Sleep disorder.
Yes, they may sleep less or more, it can go either way.
Lacking interest.
Yeah. So things that they used to find pleasurable, they no longer find pleasurable. Yeah.
Eating less or more.
Yep, eating less. So someone who's diagnosed with depression, usually in the last 2 weeks preceding diagnosis, may see some of these things. So loss of interest in food, sex, exercise, or other pleasurable activities. They may have difficulty falling asleep. They may increase alcohol and drug use in order to cope. They might be moody or irritable. And often people don't associate that with depression. They often consider it just a flat mood, but they actually may present being quite irritable and angry. So there's some of the things that you may observe if someone is depressed. Depression can affect your emotions, your thinking, your behaviour and your physical well-being. So basically there's not much it doesn't touch in terms of your life. In terms of your emotions, you can have a range of emotions, quite negative emotions, feeling helpless and hopeless, irritability, and if it's severe depression, people can feel suicidal. In terms of behaviour, you may start to see things in behaviour. They start to behave in ways that you hadn't seen before. They start to withdraw when previously they may be quite sociable. Loss of interest in personal appearance when before they used to pride themselves in looking well. They may not be able to concentrate, so that's something you may observe is their ability to follow a conversation. You may find yourself having to repeat a conversation or a question a number of times because they just can't hold on to what you're saying. The thoughts are often quite negative and self-critical. So you might hear things like, I'm a failure, it's my fault, I'm worthless, life is not worth living. So people can get so severely depressed they do tend to think about death and dying and suicide because there's nothing else they're worth living for. In terms of their physical, it's the lack of energy, the apathy, the lack of motivation. There may be weight loss or gain. Their menstrual cycle may be affected. And they may have aches and pains. So if you're observing someone, we kind of mentioned, touched on it before, how will a person who's depressed appear?
There's a variety of ways they can appear.
So there we go.
There's a variety of ways they could appear. That it could be, you could have outward signs, or they might actually cover it up and go the reverse way.
So there might be more. So if you're observing someone, this is what you may see. So they may have their thoughts, and their thinking may be slow, they may be agitated or irritable. Speech can be low and quite monotonous, and they're often quite flat, so there's no expression in their facial expression, so there's just no emotion coming through, it's very flat. Their personal hygiene and grooming is affected. Could be anxious, irritable, and easily moved to tears. There's some of the things you may observe. Mild depression, they may be able to hide it from other people, but severe depression, it's quite outward. It's quite negative, and there will be those themes of hopelessness and helplessness. A really negative view on life. Treatment for depression. First off, a referral to go and seek advice from your GP. If it's mild to moderate depression, there's no real need for antidepressant. You may be able to benefit from CBT or casework counselling. Self-help books for those who can't get out of the house. There's a lot of e-learning online for depression. And moderate to severe depression, you will need potentially medication in order to alleviate some of that low mood, in order to start working on some of the talking therapies. Any questions so far? Alright, we'll move on to anxiety. Anxiety, like depression, is a high prevalent disorder. It affects 14.4 Australians between the ages of 16 to 85 in any 1 year. More females than males experience anxiety. Just don't know why, but they do. Other words we may use for anxiety:
On edge.
stress,
Worry.
worry, scared, confused, worried. And with anxiety, we know that it has such a physical component to it, often because we know when we're feeling anxious, we get butterflies in the tummy. The heart's pounding. So anxiety is quite a physical reaction. But it does affect your emotions. Excessive fear, irritable, impatient, confused, nervous. Then our thoughts. There's lots of worry about the past and the future. Like depression, poor concentration and memory. And it's often really hard to make decisions, and we have difficult sort of holding someone down to making a decision that find that difficult. We know their behaviour, they can potentially avoid situations or people, can become, if you're severely anxious, can become quite obsessive and compulsive, because OCD, obsessive compulsive disorder, is an anxiety disorder. And we start to, in social situations, some people may withdraw from social situations because they're so anxious. And that's where agoraphobia comes from. Do people know what that is? Someone?
It's fear.
What is it?
Fear of the marketplace.
No?
It's fear of the outside world, isn't it? So basically leaving
Feels anxious about
expanded spaces. So
It's
being
fear of
kind
going
of
out and having a panic attack.
It is a fear of having a panic attack. So what you do is avoid those that particular place where you will have a panic attack. So people with severe anxiety can experience panic attacks, so you avoid that going out to that place where a panic attack may have occurred. So you actually avoid going out. So what you find, people with severe panic attack disorder will actually be housebound because they fear of having a panic attack. And then with anxiety, the physical reactions to either a panic attack or anxiety, if you have a look at that list, and if you were to compare it to a heart attack, you wouldn't really be able to tell the difference. So if someone's, for example, experiencing a panic attack or a heart attack, if the paramedics are called, they'll often have to transport the person to hospital because it's only a doctor who can diagnose the difference between the two. Because the reactions, the physical reactions in a panic attack are so similar, as we can see, to a heart attack. So it can be, people actually feel that they're dying when they're having a panic attack. It's real, the sensations are so real, the pounding heart, the tingling in the arms. And the reason why our fingers tingle is because when we were cavemen and women, we needed to fight or flight, so we needed our larger muscles like our legs, either to fight the big animal that's coming our way or to run away. So we needed all of our blood to be in our big muscles so we could run. We don't need blood in our fingers and our toes in order to run away. So that's why when we're having extreme anxiety or a panic attack, that's why we get that tingling sensation in our fingers. Anxiety disorder differs from normal anxiety. We all have anxiety. We all need it to survive and perform. Whether it's a job interview or an exam or public speaking, we need anxiety. It's a natural. It's actually helpful. It's when it starts to interfere with your ability to work and pursue activities and to sort of live your life, that's when it becomes a disorder. And it's more severe and long-lasting. That's when we know that we have a problem. Like depression, anxiety, we seek advice from your GP. And often for mild to moderate anxiety, there are psychological therapists that are of benefit, like CBT or casework counselling. Here at the Inner South, we run like depression, some anxiety and depression groups, which can be quite beneficial. Some people who have come to anxiety group for the first time, they realise what they're experiencing is not a physical complaint and a health problem, but what they are experiencing is anxiety. It's kind of a relief to know that there's not something physically wrong with them, that they can manage their anxiety, can learn strategies to reduce the anxiety and the impact it has on their life. Alright, I'm going to touch on psychosis briefly. Psychosis is a term that we use when people lose contact or lose contact with reality. So what it does, it starts to disturb your thinking, your emotions and your behaviour, so that it's really difficult to sort of function day to day. It impacts your ability to work and other activities like even just self-care can be really difficult. It's a low prevalence disorder, which means that it's not common in our community. It impacts about 0.5% in any 1 year, and across the lifetime 0.3%, but the impact of something like psychosis is huge. In terms of burden of disease, severe schizophrenia is the same burden of disease as quadriplegia or someone with late stage cancer, so the impact is huge for the community and the individual. So when we're looking at psychosis in terms of emotion and motivation, often what you'll see is a very blunted, somewhat dissimilar to depression, a very flat effect. Not a lot of emotion is potentially may not be expressed, or incongruency with what is being said and how they're expressing that in their face. So they might be talking about something quite happy but quite sad looking, and vice versa. Motivation is often impacted because in psychosis, when we talk about psychosis and in particular schizophrenia, we talk about positive symptoms, which are things like hallucinations and delusions, but then there are often people are most impacted by the negative symptoms, which is the lack of motivation, the lack of drive, the lack of interest in life. So often you may hear those terms. There are changes in behaviour where there is a withdrawal from the world and community and family. That may be for a number of reasons. That may be as a result of stigma, or it could be as a result of inability because of that low motivation, that the negative symptoms to get out and do things and carry out the roles that they used to be able to do. We know that it changes someone's thinking and perception, so they may start to have some odd ideas and odd thinking, and this is where we may see some of those delusions come through. So they may think that those alarms, I think they're alarms, they may be monitoring them, it might be the CIA or someone where they're being monitored, so they start to believe their reality is quite different to ours. We obviously know that that's not the case, but for them it's a very fixed belief. Schizophrenia comes from the Greek called fractured mind, because it really your thoughts and perceptions become disordered. So the delusions, what I mentioned before, are fixed and firm beliefs. They're false, but it's their reality. There's no point agreeing if it's not your reality, but for them it's what they see and they believe, and it's real to them. We may have heard of hallucinations, most common visual and auditory hallucinations, but it also affects all the senses, so your taste, your touch, and your smell. So people can smell things that we can't smell, but for them it's real. There may be some difficulty in memory, so your thinking's disordered. This thinking is just sort of affected, and difficulty in sometimes even organising your thoughts. So what happens is when you're talking to someone who's quite thought disordered, they're unable to either follow the conversation or unable to respond to you in an appropriate manner. So if you say, hello, how are you? I had a client once who could not even answer that question. His thoughts were so disjointed, it didn't respond to my question at all. Loss of drive. What we see often people experiencing schizophrenia is poor self-care, which includes dental hygiene, and just often malodorous as well. It's just their ability to do day-to-day self-care is difficult. Talked about before about the blunted or the inappropriate in their emotions, and social withdrawal. Often we know people who experience schizophrenia are often quite socially isolated. Bipolar, not quite a psychotic disorder, but I've put it in here anyway. It's people who experience high-ranging emotions, so they can have extreme mood swings from the extreme happiness to extreme sadness. But in the extreme happiness mania, they feel elated, they feel great, often not a lot of insight to what's going on, and these are some of the things you may see. And because they've got such increased energy, they take on the world and they take on a lot of projects, but they're not actually quite, they think they're completing tasks and being quite useful, but they're actually potentially not. There just seems to be this high energy, high buzz. And of course they would like it because the opposite to extreme happiness is obviously then extreme downers and depression, and people are really simply low. Just briefly, other types of psychotic disorders, psychotic depression. Someone who's severely depressed can often experience psychotic symptoms. And there's often also, I haven't included here, but psychotic people that postnatally can have a psychotic episode. Schizoaffective disorder, which is a combination of schizophrenia and bipolar. So you have the mood component of bipolar and the sort of psychotic symptoms of schizophrenia. And then there's drug-induced psychosis where it's brought on, being intoxicated from drugs or alcohol or withdrawn from drugs, and usually that's a brief episode. Unlike depression and anxiety, first treatment for psychosis is medication in order to alleviate some of those symptoms and manage some of those symptoms. That's all we've got at the moment. There's no cure, so we need to manage those symptoms. So some people will need to be on medication for life. So you may initially visit a GP to get a referral to a psychiatrist, or some good GPs are able to prescribe antipsychotics, and you can always discuss the referral to the mental health team. Okay. Now there's a case study. Max is a 45-year-old gentleman who's come into the health centre to see a podiatrist. He's missed 3 previous appointments. He has arrived a little late, and you notice that he is sweating and appears to be a little flushed. He is fidgety and appears to have poor concentration, as you've had to repeat questions several times. Max responds to questions irritably. When talking to Max, you've ascertained that he has difficulty leaving the home and therefore misses lots of appointments. What is going on for Max, and how may you draw him out?
Anxiety issues. Yeah.
So how will you approach that with Max? What would you say if you're doing a common assessment? If you're doing a common assessment and he's coming to see you. Is there any podiatrist? Yeah, so he's coming to the podiatry, you're doing a common assessment, this is what you notice, what would you be asking him? Because depression and anxiety are the mental health on the common assessment.
I guess
you can see the doctor, and does he see his doctor regularly?
What for?
What was the last time he went for and what was discussed? Just checking with you.
Because you're noticing these things for Max, what are the, so we know it's anxiety, so how may you draw him out about his mood?
Might just say it to him and say, oh, I've noticed this, blah, blah, is there anything going on for you you want to talk about?
Have you spoken about it to anyone else?
Has he noticed the change in himself?
So I guess what I'm trying to get at here is that someone may present initially, he's missed 3 appointments because obviously having difficulty getting somewhere. And that hadn't been picked up previously, the reason why he hasn't turned up. But now that you know that he does potentially experience from anxiety, it's your opportunity to try and engage with him and link him into potential supports, because he may not know that he's experiencing anxiety either. Because we know because of the National Mental Health Wellbeing Surveys that people live in community without knowing that's what they're living with.